Okay, we're going to get started. Come on in. Welcome to those here in person and online to the next seminar in the Research Skills Seminar Series. My name is Sue Scull and I run the Research Education Program here at CAHS, and over the course of each year we deliver over 20 different seminars that touch on different important aspects of the research process. And for those who haven't been to one of these before, they're always really big topics, and we try and keep them condensed to 1 hour to give you an overview and then point you to your handouts for extra resources, training opportunities and so on, because we know that our audience consists of busy clinical people, so we're very aware of how important your time is. Do fill in your evaluation link when you get sent it after the seminar today, because we will take on board your feedback and try and improve what we do. And do send in questions at the end if you're offline, and we'll hold our questions here in the lecture theatre till the end so that everyone can hear them with the benefit of a microphone, and so that we've got a recording that's uninterrupted, because we do put all our seminars online the following week, each time we deliver one, if you happen to miss one. They are there all the time. So this is a really important topic. Thank you for those of you who've realised that. So as a clinician, probably, even if we're never involved in research directly ourselves, the most important skill that we can have is being able to interpret other people's research, and that's why we read scientific papers. And it's very important to be able to pull apart the numbers and see if the conclusions that other people have reached are actually reasonable given the data and given the methods. And that's what critical appraisal is all about. So before I start, I'd first like to acknowledge the traditional custodians of the land on which we're meeting today, the Noongar Whadjuk people, and pay my respect to their elders, past, present and future. So today what I'm going to cover is where this fits into evidence-based clinical practice, which is what we should all be doing, and what critical appraisal actually is and why we need it. Then we'll drill down into some critical appraisal strategies and look specifically at validity and interpreting results, and then how we go about deciding whether to apply results or not in our own practice or wherever it is that we work. And because in clinical practice, and I'll come to this in more detail later, the most common types of questions we ask in clinical practice is, if I change this, will that provide more benefit or cause more harm? And those sorts of questions are best answered by randomised controlled trials. So we're going to be focusing on the structure of clinical papers, but putting a little bit more emphasis on randomised controlled trials, because they're the papers we should most often be reading. So what is evidence-based clinical practice? It was David Sackett, who's was an amazing Canadian epidemiologist, who first came up with this concept and defined it, and he passed away in 2015. But he described evidence-based clinical practice as the integration of best research evidence, which is what we're about today, with our own clinical experience and then the values of our patients or our colleagues or wherever it is we're working, where we're trying to improve things. And that involves these 5 key steps. So firstly, formulating a clear question so that you can then go and find the best evidence to answer that question. And he came up with this PICO framework for questions, which you may have heard of. Not everyone puts the T at the end, but P stands for the population or participants or patients of interest. I is the indicator or intervention of interest. C is the comparison group, if there is one, there may not be. O stands for the outcomes that we're interested in, and T is the time frame. So when you're thinking, what question do I want to look at, those are the 5 key things that will help you write a clear question. It's really worth using that framework. It's simple, and then you don't leave anything important out. So once you've got your clear question, you can go and look for the best evidence to answer that question, and then critically appraise it, which is what we're going to talk about today. And then we can go about the business of deciding whether to integrate that with our practice or not, and we have to take on board our patients' values and our own experience, and then evaluate that. So what's critical appraisal specifically? Well, Amanda Bells was with CAHS, the Centre for critical appraisal and, what does it stand for? Critical Appraisal Skills Program from Oxford University, and she was there from its inception. And there are many definitions, but I like this simple one, which is that it's the process of carefully and systematically examining research to judge its trustworthiness, its value and relevance in a particular context. And I think it's true what she said with Paul Glazier, a Queenslander, that a 21st clinician who can't critically read a study is as unprepared as one who can't take a blood pressure or examine the cardiovascular system. And obviously they were talking about doctors, but today I'm talking about all clinicians, because we all need to be able to read papers and critically evaluate them, particularly in this world of Dr. Google, when a lot of the people that we are seeing in our practice are looking stuff up online that doesn't actually necessarily have a good sound evidence base. So we need to be able to pick through that. So why do we need critical appraisal? Over the next 5 minutes, I hope I'm going to convince you that it's not simply a matter of picking up a paper and reading it. It's not always going to be good evidence. First up, we've got a moral obligation, professional obligation throughout our lives as clinicians to maintain our knowledge and skills and keep them up to date, and then apply that up-to-date knowledge and provide the best evidence-based clinical care. But there's just so much evidence to keep on top of. It's just about impossible. And I just pulled out a few numbers here about, 1 million biomedical concepts, 5 million concept names. There's new diseases, new diagnoses, new tests, new drugs being developed every day. So it's really important that we don't try and cover everything. And when you look at research papers, just in PubMed alone, there's over 1 million papers published every year. So that's like a couple every minute. And when I've spoken about how to focus what sorts of papers you read, or you should read, and we think about randomised control trials or the studies that condense the evidence from several of those, even when you do that, the number of randomised control trials being published is increasing exponentially every year. And even back in 2008, you would have had to have read 500 randomised control trials a week just to keep up. So we just can't do this. We've got to be selective. And certainly when I started medicine 100 years ago, I took this approach, and everybody did. It was just in case learning. You would read entire textbooks, or you would subscribe to journals and read the entire journal. And that was just in case something in there would come in use or be handy in future. And that's all very well, but it's very hard to keep up with it. But the other important issue about that is a lot of books sitting on shelves and journals sitting on shelves are already out of date by the time you get back to them. And a lot of evidence, because of that, never gets used. And I've written, what's the meat in clinical journals, meaning what's the proportion of actually high quality, clinically relevant articles, even in the very best journals with the highest impact factor? And it's actually really small. So you can see even for journals like New England Journal of Medicine or JAMA or Lancet, it's sort of around 10% or less are actually articles that are directly clinically relevant. So because of that, we need to move from this just-in-case or push learning to what's now called just-in-time learning. So we need to think about what are the current clinical issues facing us that keep coming up again and again or are important for wherever it is that we work, and then be able to turn that into a question and then go and find the relevant information. And the best place to start is someone else's critically appraised topic. So there are actual things called cat banks where people have put into repositories their own summaries of reading the literature in that area to that specific topic. And the Cochrane Library is a really brilliant example of that, where it contains meta-analyses of pooled, usually randomised controlled trials to answer specific clinical questions. And journal clubs do this too, evidence-based journal clubs. So it's a great way to start if you've got a burning question, rather than heading to the library and starting from scratch. See if you can look up one of these cat banks and see if there's anything in there. And I've put several of them in your handouts, which will have all been emailed. I should have mentioned we're trialling not giving you handouts because of paper, and also because there's really good evidence that you learn more if you're not reading and writing and listening and watching all at the same time. But you tell us what you think. And I've written at the bottom, we might improve on the fact that only about 50% of valid current evidence ever gets used because we haven't got time and we're not being efficient about what we do. So we need to be able to find evidence more efficiently, and then we have to be able to appraise it quickly and effectively because we're all very busy, and then apply that evidence systematically to policy and practice. And this is a really important concept. If you only go home with one thing today, it's what's on this slide, and I'll go back to, in a minute, to the hierarchy of study design. But the bottom line is different types of questions are best answered by certain types of research study designs. So depending on your type of question, you need to go and look for particular sorts of articles to answer that. And there may be more than one option, and you go for the highest level of evidence you can, which I'll talk to in a minute. So if you're just interested in how common something it is, you're not going to go looking for randomised controlled trials, you're just looking for, that's a prevalence type question, you're just going to go and look at some surveys from different places. If you're interested in early detection or screening, that's a type of cross-sectional study. Diagnostic test accuracy, that's another type of cross-sectional study. So cross-sectional studies are surveys, audits, that kind of thing, or comparing one test to another. If you're interested in what caused a condition, then that's a risk factor type question, best answered by a case control study. If you're just looking at natural history of your condition and what happens if you just follow it with time, that's a prognostic type question and best answered by a cohort study. And then, as I mentioned at the start, the most common types of questions we ask in clinical practice are actually whether changing our practice or introducing a new intervention, whether that's going to cause more benefit or more harm. And those are intervention or treatment type questions, and they're best answered by randomised control trials. And that's why this is going to be the focus of today's talk. And what you need to do when you're reading an article too is also look at whether the best design has been used to answer that question, because there's sometimes more than one choice. And you need to go, if you're looking for a particular study, always choose the highest level that's feasible. And it's also an important concept that not all studies are equal in terms of the way they can be interpreted. So simple descriptive studies like case series and surveys and audits, the results are just the results. So you can't imply anything from them. You just measure something and you look at it, and it might be mortality rate or it might be prevalence, but you can't infer anything from that because it's just a snapshot in time. So those are hypothesis-generating type studies, observational studies, qualitative studies, and they're really important, but they're not as high up the tree as the hypothesis testing studies, otherwise called analytic studies, and those are the case control, cohort and randomised control trials. And we're going to talk about that next. So this is I'm an epidemiologist, this is the good old pyramid or hierarchy of study design, and you'll see right down at the bottom is what we fondly call BOGSAT, the bunch of guys sitting around the table. This is opinions, anecdotes, editorials and ideas, and honestly sometimes that's the best level of evidence we have, and it's not to discount it because experience is really important and sometimes we don't have other research studies out there to draw on. As you go up, the observational studies which have lower level of quality of evidence, if you like, and a higher risk of bias, those are the audits and surveys, case series and case reports. And then above that, they get stronger and stronger in terms of their design, the quality of evidence and the lower risk of bias. And that's because with those designs, you can start adjusting for factors that can make the waters murky, if you like. So you're adjusting for confounders, you're reducing bias through design. And so that's why randomised control trials are right at the top of all those single study designs. They are the most powerful study design because of the process of randomisation, adjusting for known and unknown confounders, and I'll talk about that in a minute, as long as they're done well. And then systematic reviews of well-conducted randomised control trials sit above that. because we know that if you do one study once in one location, it's going to have a different result if you do it another day in another place, or even in the same place. So putting together data from different similar studies is much more powerful than if you've just got a single study. If you're only doing systematic reviews of cross-sectional studies, systematic reviews would only appear just above that line. So when it's higher up the pyramid, it's referring to systematic reviews of randomised controlled trials. And above that are the meta-analyses, where you actually pull out all the data of similar studies and pull it together. And that's what the Cochrane Library does. So when you're faced with what are the options for answering this question, you go as high up the tree as is feasible, or as high up the tree as there's evidence for that question. The next reason we really need critical appraisal is we're actually not good at telling good research from bad research. So if you know the British Medical Journal, it's a very prestigious, high-end journal with a high impact factor. And Schroeter and colleagues did this great little study a few years ago in 2008, where they took over 600 people who reviewed for the British Medical Journal. So you'd like to think that when you read the British Medical Journal and you're reading an article, that it's going to be tip-top, high quality, and there's not going to be any problems with that article. Well, nothing could be further from the truth. So in this study, they gave these reviewers a paper to review, and they inserted all these deliberate errors, which they assumed that people would pick up. And they put in 9 big errors, which would normally be enough for you to put the paper to one side and go and find something else, because you wouldn't be able to trust the results, and 5 minor errors. And on average, less than 3 of the 9 major errors were picked up. And they were really big things like inappropriate randomisation and not doing intention to treat analysis and poor response rates and so on. And I'm going to talk about all those things and why they're important. But it means that just because you're reading a tip-top journal, and we've all heard about disasters like the autism and MMR and the Andrew Wakefield, that was in a high-end journal, and that had been reviewed and people hadn't realised there was a problem with it, and then it affected millions of people. Also beware of predatory journals. Hopefully some of you know our very own wonderful Western Australian of the Year, Mike Daub. He's very passionate about alerting people to the fact that there are some really low quality journals out there, and these are actually a scam, and many of you will have probably received, you know, dear esteemed colleague with sort of not very good English and lots of adjectives about how wonderful you are. We'd love you to be a reviewer for our paper, or please submit one of your amazing research articles to our journal. And these are journals that require you to pay to publish. And in this world of publish or perish, many, especially junior researchers, but many senior researchers get caught out as well. The opportunity to quickly get your article published is very tempting. And Professor Olivia Dole is actually on 7 editorial review panels, and she's published many papers in these predatory journals, and she's actually Mike's staffy, his pet. And that's despite the fact that she's got a profile page with a picture of Kylie Minogue and a whole lot of absolute, you should read this stuff, it's just fabulous and quite entertaining, but obviously as a reviewer she's not going to be very good, and yet she's on the editorial board of 7 different journals, and the information that he puts up about her is quite transparently false, and the articles that she writes are quite transparently ridiculous, and yet she's got them published in many places. So you need to be aware of these journals being out there and not get involved with them, and hopefully at some point there'll be some certification process for journals so that we can be alerted that they're not proper journals, but just be aware that everything you read out there is not necessarily good quality for a number of reasons. And not all research is useful for a number of reasons, and this is another good paper, and one of the things it focuses on is the fact that poor design results in poor data that you really can't apply, and that's what critical appraisal is all about. All research has faults. When you're reading something, does it have enough faults for you to go, I'm going to put that to one side and go find something else, or are you going to be okay with it? So let's talk about critical appraisal strategies after that background. So just revisiting what it is. I like to go through these 4 things, and if the answer to any of these 4 things in yes, I do tend to put that paper aside and go and try and find a better one. Sometimes there isn't one and you just have to make the most of what data are there. But firstly, is there a really clear question, and then have they matched the right design to the question in order to be able to answer it? And have they used strong methodology to enable that to result in robust data? And then if the data are robust and the question is clear and it matches what you're interested in, are the results important? So is the finding really persuasive? And there's a number of different ways to look at that, and we'll cover that. And then after that, if the data are strong and robust and persuasive, can you actually apply them wherever it is you work? So there's lots of things to think about. And as I said, the key concepts of critical appraisal involve the fact that there's no such thing as a perfect study, and therefore there's more than one possible explanation for the results in front of you. So in the perfect study, the result would be the truth, the real value. But frequently there are issues, mistakes, problems with design, problems with training or monitoring staff or whatever it might be, or confounding variables. And then of course the other option is that it could be a result due to chance, because every time we bring in statistics we're bringing in assumptions, and sometimes things just happen by luck. So you need to be able to tease that out. And then the other key concept is you can't apply all results wherever it is that you work, because the population might be completely different, or the setting might, or the participants might have been too different to yours. And that's mine at the bottom. Don't change your practice, if possible, based on just one paper, because as I said, you repeat the same study next week in the same location, you'll get a different result. You repeat the same study in a different location altogether, you'll definitely get a different result. And that's why systematic reviews and meta-analyses are more powerful than just a single study. But sometimes there only is one paper, so you've got to be able to assess it. So validity is a key concept, and what we're after is accuracy and precision in the results, and that depends on a whole lot of things. So the design, the conduct, the analysis and the interpretation of the study and its data. And as I mentioned, there are some key things to look for. So bias is where you've got systematic error, and we'll talk about the fact there's lots of different types of bias, but that might be due to the fact that someone on your staff is systematically measuring something incorrectly because they weren't trained properly, or things have drifted over time, or people getting the intervention are more likely to remember things than people not getting an intervention. There can be a whole lot of reasons, or the recruitment issue is really important if you haven't got a representative sample to start with, or a whole bunch of people dropping out. So systematic error is bad, random error is not so bad, and a good example in paediatrics is we're always taught to measure head circumference more than once, and each time we measure it in a Wrigley child we'll get a slightly different result, but all those results will be clustered around the real result, as opposed to a systematic error when someone's regularly just totally measuring something wrong and it's always in one direction. So random error or noise is not such an issue. Confounders are a really important concept, and I've put some information in your handouts about that, but a confounding factor is something you can see an association between an exposure and an outcome, and a confounder is not on that pathway, it's out here somewhere, but it's actually related to both the other things. And the classic example is that of smoking and lung cancer. So we all know smoking causes lung cancer now, but in the earlier studies they thought it might be coffee drinking, and coffee drinking doesn't cause lung cancer, but it was related to both lung cancer and smoking, and that's because people who smoke tended to have a coffee at the same time. So that's an example of a confounding factor, where if you weren't adjusting for coffee drinking, you might be under the mistaken impression that that was the cause itself. So you need to be able to look at different methods for dealing with confounding variables. And it's things in the design and the conduct and the analysis that can improve that. And this is a good point in the talk to mention that in your handout I've put numerous different sources of really fabulous checklists for doing critical appraisal, and you should pick one according to the study design. So there are ones for randomised controlled trials, there are ones for cohort studies or case control studies or surveys, so that's all in there. And as I said, we're going to focus on randomised controlled trials because they answer intervention type questions, which is by far the most commonly asked type of question in clinical practice. So when we're reading a paper, what we want to see is that the authors have thought about minimising the opportunity for confounding factors to mess up the results. And by far the most powerful is to do this in the design, not fix it later in the analysis. And by far the most powerful way of doing this is randomisation. So that's why randomised controlled trials sit at the top of the pyramid. And that's because, in theory, everybody has an equal chance of ending up in the intervention or their non-intervention control group, which means that in theory, if you've done that properly, everyone has an equal distribution of all those potential confounding factors. The ones you know about from doing your reading and the ones that we don't yet know about it should all be equally distributed. And that's why randomisation is so powerful. And then the only things you're comparing is the effects due to the intervention or not. So that's why it's so important. If you can't do randomisation, and there's loads of things you can't randomise because it wouldn't be ethical or feasible, then you can do other things, such as restriction, where you just take out the confounder altogether. So you only do a study on women and you take the men out. And that's really easy and cheap to do, but it does mean your results aren't very generalisable. It limits who can go in the study. And then probably the next most powerful to randomisation, if you're doing a case control study, you take a whole bunch of people with an outcome and a whole bunch of people who don't have an outcome, and then you look backwards in time and see what their risk factors were, and you try and predict which ones might have caused the condition. And so picking the controls is really important, and it's really hard to control for all confounding variables, but we tend to try and match on things like gender or age or demographics or whatever it is you think is important. But the more you match, the more you end up watering down things as well. So you can end up with trouble from overmatching. And of course you need to do clever analyses as well, like matched pair analysis and conditional logistic regression and other things, but that's why you go see a statistician. And then all is not lost if you can't fix confounding in the design. So you might see when you're reading a paper that it's not a randomised controlled trial or they couldn't do any of those other things, but when they come to the analysis, they can either stratify by a potential confounder and see if the two groups have different outcomes, like men versus women or old versus young. And if the results are similar, then that's reassuring. It's probably not a confounder. But the most powerful is what we all do these days, is use a package like Stata or SPSS or whatever it is, and put in all the confounders into a multivariable analysis statement, and then you can try and adjust for as many things as you can think of. But it's not perfect. It's not like randomisation done well, because there'll be confounders you don't know about that you didn't collect information on. There's a whole lot of other ways too, but that's the sort of thing you're looking for. Now, there's so many different sources of bias, and I will talk about some of these today, but just briefly touch on sampling. Obviously, you want to be able to generalise the results to the population that your sample was drawn from. And as I said at the start, if it's a perfect study, then the perfect design would be to have everybody who could possibly have this condition in your study, but realistically that hardly ever happens because we don't have the resources. It's just not feasible. So we need to take a sample, and if we don't do that well, we end up with a really unrepresentative group of participants right from the beginning. And you need to have a look at how they selected their participants and how they recruited and consented them and where did they come from and what age were they, and basically what were the inclusion and the exclusion criteria. And that also helps you decide later on whether you can apply the results in your setting. We're going to talk about randomisation. Compliance refers to just whether in a randomised control trial people actually got the intervention, because sometimes that doesn't happen, or sometimes people in the non-intervention group somehow go and get hold of the intervention anyway, which is contamination. Or there might be co-interventions where a whole bunch of people who don't get the intervention somehow know this, and their doctors give them a whole stack of other things. And that's okay if it's the same in both groups, but it's not great if it's all in one group only. And it's not great if there's a lot of it. So there's a lot of different things to look at for bias, especially measurement bias, and that comes down to often just training of your staff, monitoring your staff, getting everyone to do everything the same way all the way through. So let's look at a few of these little things, particularly for controlled trials. So I said to you that randomisation is the most powerful thing you can do when you've got an intervention, so that we're distributing all those known and unknown confounders. So if you're reading a paper, you need to look at table 1, which is usually a baseline table of the intervention group and the control group, and you want to see that roughly they're all the same age, roughly they're similar gender balance, roughly similar number of comorbidities, and so on, whatever you think is important. And it's not a p-value thing, it's an eyeball thing. You have to decide, is that okay? And if you decide it's not okay, that's fine. You then go to the results and the analysis and see that they've adjusted for those differences or not. And just because someone's randomised really well, if it's a really small study, randomisation can still fail. So you can imagine that if I tossed a coin 10 times and 7 times it came up heads, you'd go, that's a bit odd, but that's probably what happens. But if I tossed it 1,000 times and 700 times it came up heads, you'd think, there's something wrong. So small studies can have failure of randomisation just because of that luck, really. So that's why bigger studies are obviously better. Okay, so I mentioned why it's important that you read somewhere that in controlled trials that the groups are treated equally, and that's because otherwise you're not comparing apples with apples. So if everyone in the intervention group also got antibiotics and meditation and 5,000 other things, then it might not be the intervention that caused the positive outcome. So you want to see that somewhere they've described co-interventions, and that ideally it's infrequent that there are co-interventions and it's equal in both groups. So that's the sort of thing you're looking for. Loss to follow-up is a biggie too. So it's really important that in a study where there are multiple data points and perhaps not everybody finishes for whatever reason, that the overall loss to follow-up in that study is small. So at the start of a study, people will pick a sample size that enables them to be confident about the results. And if you end up losing a whole stack of people, then you don't meet that sample size, then you're going to end up with very results that are not necessarily robust or real. And what you're looking for is that the loss to follow-up is described in each group and that it's small. And the 5 and 20 rule is not strict by any means, but if there's less than 5% loss to follow-up, then we don't get too fussed. But if it's more than 20%, it starts to become an issue. So, for example, if the intervention has a positive outcome and people do really well in the intervention group compared with the non-intervention group, but you've lost 20%, or say you've lost 50% from each group, what you have to then do is sensitivity analyses, and you might do this as the reader, or hopefully they've done it for you in the paper. But say the 50% missing from the positive outcomes group, you assume that all of them had a negative outcome, and in this control group, all of the 50% that were missing had a positive outcome. Could that change the overall results? And the answer might be yes, in which case you then have to decide, well, how likely is that might have happened? So it's a value call again. It's like you've got to judge. But doing those sensitivity analyses is important. And as soon as you go over about 20%, it's possible the results might actually change between the groups. And then the other thing that's important is you want to see that loss to follow-up is equal in both groups. So as I said, if you're losing lots of people from one group only, that could really affect the result. So, and that happens. So when the intervention group's doing really well and people don't finish, or people in the intervention group have some disgusting medicine and they don't finish taking it or don't finish the study, or a whole bunch of people in the control group die, for example, then that's problematic for the overall results. Oh, this is a great article with silly pictures. But you've probably all heard the terms single blind, double blind, triple blind, and it's confusing, and masking. Masking and blinding are the same thing. And we need to ditch single blind, double blind and triple blind. It doesn't tell us anything. What's blinding? Blinding, well, randomisation is all about controlling for confounders. Blinding is all about preventing bias. So once people have been randomised to groups, you want to know that the participants themselves don't know what they're getting, and the people assessing the results don't know what they're getting. Why? Because it's really common that people work harder to get positive results for interventions they're invested in, whether they're the investigator, the clinician on the ground, or even the participant. So you might encourage them more to do that little bit harder on the treadmill and get slightly better results, or you might slightly more favourably interpret results in favour of the intervention, for example. So blinding is critical, and what's important in a paper when you read it is, did they do blinding? How did they do blinding, and did that blinding actually work? And then who was blinded? So you can't blind people to every intervention. So a good example might be something like a bunch of people might get compression stockings or not for long-haul flights to try and prevent deep vein thrombosis. Obviously you're going to know as a participant whether you got those stockings or not. But if you whip them off long enough before the ultrasound's conducted at the other end looking for deep vein thrombosis, then at least the assessor doesn't know which group the participant was in, and the participant has to zip about which group they were in. So how the blinding was done and maintained and who was blinded is really important, and if you can't blind everyone, you must blind the assessor. That's the most important, because they're the people who actually write down the results, and if they're all biased, that's a big problem. So the bits at the bottom are what you want to read in an article, how they did it. And there's a long history of people holding up randomisation envelopes and steaming them open and holding them up to the light, and all sorts of things have been done to unblind participants because you desperately want this person to get the intervention because you believe in it, etc., etc. So it's just really important that it's done well. Okay, now intention to treat analysis is another thing that people get confused by, and that's the concept in randomised controlled trials that you analyse people in the groups that they were put in, and that's regardless of whether they ever got the intervention, whether they died or got sick or forgot to take it or actually went into the other group, whatever it might be. And that seems a bit weird, but why is that so important? Again, it's to preserve randomisation, and if we don't preserve randomisation, we're not preserving the whole point of that, which is to equally distribute confounding variables that we know and don't know about, so we're comparing apples with apples. And you can imagine, for example, that if the intervention is surgery, for example, and a whole bunch of people don't get the surgery because they were too sick, for example, and you take all of those people out because they never got the surgery, then even the worst surgical intervention is going to look really great because you've only got healthy people in that surgical group, but you've still got unhealthy people in the control group. And that's a real issue, and we know that that overinflates the benefits of things. So we've got to keep people in their groups, and that's kind of life if some people sneak off and get an intervention some other way or don't take it because of compliance issues or whatever it is. Okay. Interpreting the results. This is a really good paper that Julie Marsh picks apart entirely in a whole seminar, a separate seminar, which we've got on our website if you're interested. And it's got a more statistical approach, I guess, than just simple critical appraisal, but it's a really good companion seminar to this one if you're interested. But for me, the big ticket items, as I've written for interpreting results, are using your common sense, having a look at the size of the measure of effect, so that's things like odds ratios, relative risks, whatever it is. How big is that effect? How much of a benefit or how much harm might you be seeing? And then is it precise? Are the results precise? Are you confident in them? And then can they be applied in your setting? So common sense first. The father of common sense was Sir Austin Bradford Hill, who described all these things on this list, and since then people have described a whole lot more things that you can look at when you're reading a study and the way the results have come out, to decide in your own mind, do they make sense or not? So how big's that association? Is it a 10 times improvement versus a 1% improvement? So that's important. Is it consistent with other studies? Are the results specific? So if you repeated them again and again, or you've seen it in other studies, are they all are they consistent in that location or in that population? That gives you more confidence. Is there a temporal relationship? So does the chicken come before the egg? Does the exposure come before the outcome? Does it make sense from that point of view? Is there a biological gradient? So if you give more of something, do you get more benefit? That's always reassuring. Is it biologically plausible from what we know from science? And is it coherent with things like laboratory studies or animal studies? It's obviously not essential, but it all adds to the weight behind you feeling confident in the results. And I've added relevance. So people get hooked up on, it's statistically significant, but if this drug only resulted in a 1 millimetre reduction in your blood pressure, who cares? You want bigger changes than that. So just because something's statistically significant doesn't mean it's clinically relevant. So use your judgment. Which brings us to don't be distracted by statistics. So the thing about statistics is it's all about describing the impact of chance, and every statistical test has its own assumptions. So it's already manipulating things, if you like. So statistics can't fix bias, and it can't tell you how important something that is. You have to tease that out of an article. So some of the sorts of things you can do are the things I've listed here. So have the authors reported on their primary objective, or have they gone off on little sidetracks and looked at a whole lot of outcomes that the study was never designed to answer or not powered to answer? And have they looked at harms as well as benefits? And have they used confidence intervals around their measures of effect, which we'll come to? And you can actually pull out the numbers and look for things like how many people dropped out, or why were people excluded, and so on. And you just need to check that some basic things like, did they meet their sample size, did they use the right tests, and so on. And sometimes you need people to help you with that stuff. And always check author interpretation. I always say to people, we all do it, but don't just read the abstract. The abstract often bears no resemblance to what's actually in the results section, because people selectively report stuff the study was never designed to answer because it's more interesting, and it's quite hard to get things published if they don't have exciting findings. So people frequently overstate the results or selectively report the results or misinterpret the results. So sometimes people actually don't understand p-values or confidence intervals, and they've actually got it wrong in their conclusion, and the reviewers haven't picked that up, and then you've just read the abstract and if you don't unpick it, you'll discover that you shouldn't have gone and applied that in your practice. So moving on to the size of the effect. This is almost a bit scary as a researcher, to think that all these important people like world famous epidemiologists and New England Journal editors and so on want to see a threefold increase in risk or reduction in harm or whatever it is. So in other words, a 200% change before they're interested in publishing something. And that's hard, because most studies we do don't find such huge effects. And it's hard, but what they're saying is they're less interested, they're less persuaded by it. So why should that be? Well, hopefully some of the things I've already told you have convinced you already, but there's no perfect study. There's always opportunities for confounding factors to be in the way. Remember that everything you do is just an estimate on that day in that population, in that setting. And there can always be bias in the way things have been done. There's always assumptions from statistical manipulations and and formulae, and then publication bias is a huge problem as well. So really that former slide is telling you we have publication bias, and that is meaning that studies that don't find an impact, so there isn't an improvement, are much harder to publish. And that means that if you're reading a meta-analysis or a systematic review where they've pulled studies together, but they're all the positive ones, they've actually done studies to show that on average, interventions that have no benefit at all have an average relative risk of 1.5, meaning a 50% improvement because of publication bias. So it's an absolute scourge in the medical literature. And you have to be aware that that's reality. And the journals are aware of it and trying to do better, but, you know, who wants to read no effect? But it's actually really important. Which brings me to summary measures of effect. Nothing could be more boring or dry, really, but this is important stuff. So here we're talking about analytic type studies where the outcomes that we're reading about are prevalence and incidence and relative risk, odd ratio, risk differences, relative risk reductions and so on, or for continuous variables, means or standard mean differences. But if you were looking at diagnostic studies, it would be those other things, sensitivity, specificity and so on. We're just going to focus on the top ones. Boring but important. So I hope many of you know some of this stuff already, but it's good to just quickly summarise it. So prevalence is how many people have something right now out of the number who could. So how many people here right now are wearing glasses out of the total number? That's prevalence. There's no rate, it's just a number of events. Whereas incidence is the number of new events over a certain time period out of the people who could get that, newly get that. So of the people who don't have glasses today, you're the eligible ones, how many people would need glasses by the end of the next 12 months? That would be the incidence of people needing glasses. So they're different. A relative risk is just the prevalence in one group divided by another. A risk difference is just the prevalence in one group minus the other. And the relative risk reduction is just 1 minus the relative risk as a percent. And the number needed to treat is 1 over the risk difference. Now, why does that matter? Those last 4 things are all derived from exactly the same data. And sometimes people present data differently in their paper to impress you more. And that might sound silly, but it's actually really important. And this is a really nice little example I found in medical decision making. So this was basically talking about a drug that hopefully reduced heart attacks by lowering cholesterol. And depending on how the results were presented, they asked people would they be likely to accept the therapy or not. So same data presented in different ways. So in the drug group, the risk of heart attack was 2.5%. And then in the control group it was 3.9%. So that's a risk difference of 1.4%, and about 40% of people said they'd have it. But if you presented it as a relative risk reduction, which is 1 minus the relative risk as a percent, well, you can see going from 3.9 to 2.5 is about a 34% reduction. And that sounds much more impressive, doesn't it? And 88% of people said, I would change my practice based on that. Whereas number needed to treat, which is what often people use at the coalface talking to patients, is actually quite a nice way of describing things. So you'd need to treat 71 patients for 5 years to prevent 1 heart attack. Only about 30% of people said they'd be persuaded by that. So that's important to know, but then also important to know is that anything that's relative, so the relative risks, they depend on the baseline rate, right? So if that baseline rate is 10 times lower, so you're only talking about a risk difference of 0.14%, so you've gone from 0.39 to 0.25%, you'd have to treat 710 patients for 5 years to prevent 1 heart attack. So that's looking pretty unimpressive, but it's still a 34% reduction in heart attacks. So that relative risk reduction is still 34%. So you've got to be aware of this stuff when you're reading papers, and especially abstracts, because it's really easy to inflate results to look more impressive than they actually are. So look at the numbers. Okay, precision. All right. I shouldn't even have p-value on there because you should never look at p-values by themselves, but What you're interested in is how accurate and precise the measure of effect is. So if the relative risk is 2, that means you're twice as likely to have benefit if you got the intervention than if you didn't. But if the confidence intervals are -5 and +10, then you're going, whoa. If that crosses 1, which means there's no difference, then that suggests there's something wrong. It's probably not something you're confident in. Whereas if it was 1.9 to 2.1, you'd go, yep, that I'm feeling much better about. You also want to check that the authors have considered all the important variables, and if they've needed to make adjustments to allow for that. So, for example, in terms of whether something's robust or not, have they done those sensitivity analyses? Have they looked at men versus women? Are there some other strange confounding factors going on, or did a whole bunch of people drop out of the study, and did they do any adjusted analyses to allow for that? So you really want to see that they've done some sensitivity analyses around that. So I will come back to p-values because I hate them, and almost no paper now will have results presented just with p-values, and most journals are refusing to allow that. And the reason for that is they're just a measure of chance that we make up and we arbitrarily set at 0.05. And if something's less than 0.05, it means it's unlikely that it could have just happened due to chance, that we feel it's more likely to be a real result. But it doesn't tell us if it's true, and that's the problem. People often just think, well, it's less than 0.05, it's really important. It doesn't mean that at all, and it doesn't tell us anything about precision or how big the sample was. So we never use a p-value on its own. We do a whole seminar on this if you're interested, but confidence intervals is what we want to look at. So as I mentioned before, if it's a really narrow confidence interval around a measure of effect, we feel much more confident that that holds the real result and that we're going to pay attention to it. Again, it's something that's arbitrarily set. And I think there's a couple of really good things that you can look at. So as I mentioned, if a confidence interval contains 1, then that means one group versus the other group might be exactly the same. So there's that potential that there really was no difference. And when people are comparing two groups, you want to see that the confidence interval for the measure for each group doesn't overlap. Because if it overlaps, that means potentially there's no difference. So it's a really important reviewing skill just to have a look at those confidence intervals. And obviously the more people you have in a study, the more precise your result's going to be. So that's an important thing too. Big studies, more believable than small studies. Okay. And finally, can you apply the results in your setting? So this is where you want to look at generalisability and applicability. And I've already mentioned this, but you go back to the inclusion and exclusion criteria of the participants in a research project in the paper. Are they likely to be representative of the broader population they were drawn from? Was it what they did reasonable when they chose those people? And are they going to be particularly different to the people that you want to apply the results to? And it might not be a drug, it might just be a change in practice in a particular type of clinic, but it's in some country that's totally different to where you are. And you might go, well, on balance, the results are robust and the methods were great and they were precise, but at the end of the day, I think the population was just way too different for me to be automatically able to apply it here. Maybe you're going to be happy with that. So those are the things to look for along with those dropouts. And so they might have had might have determined in advance their sample size, but they never met it, for example. So you need to look at a whole bunch of different factors. And then again, go back to the fact that not all papers remember to look at harms, or they might have discreetly chosen not to publish them. So that happens too, particularly when drug companies are involved. Things are very much more transparent these days, but sometimes people design studies not even to look for harm, just to look for benefit. So you want to be wary of that, and assuming it's there, make sure the benefits outweigh the harms from your point of view. And then talk to the people that you're thinking of changing practice upon, whether it's a clinic, whether it's a patient, and ask them what they want. You also have to think about feasibility and affordability, and you also need to, it's changing up here, isn't it? You also need to think about what if you do nothing. So what other options do you have? Are there other papers out there looking at completely different interventions? And do you have enough information to make a decision? It's not moving on here, so bear with me while I turn around. I mentioned all these different checklists just to remind you that I have put several sources of different checklists, and really some people love long, really detailed checklists when they're reading a randomised controlled trial or a cohort study or an audit or whatever it is, and other people like super short ones because they've got 10 papers to read and they just want to go boom, boom, boom. So it's worth having a look at which ones you like. They're all really different, and you can make your own too, but depending on the type of study, you will go for a particular type of checklist. So that's an example of what investigators use when they're setting up studies as well. That will guide them as to all the important things to include and write about when they're writing up their papers. And these days you pretty much can't write up a randomised controlled trial unless you've submitted the trial in advance and followed the consort statement. And this is just a little plug for you to all go forth and set up evidence-based journal clubs, because it's a really cool thing to do, and then you can make your own cat bank in your department, and it stops people having to do the very same review next year or the year after when everybody changes and no one can remember what you've already done. And people have done studies on journal clubs, and if you bring food, that's better. They work more effectively, and you need to have these checklists with you, and it works better if you don't make one person pick apart the entire paper. It works better if you get people to work on different aspects and share the load, and you can get through lots of topics in no time at all. And actually that bottom point is really important. So keep a list of the papers you've read, or the questions you've asked, the papers you've read, and what the bottom line was when you did do the critical appraisal, and then it's there for your department or wherever it is you work next time. So these are my take-home messages. Be really efficient about what you read and try and read to answer current clinical questions. Don't try and cover everything. Don't subscribe to 47 journals because you'll never read them all. And understand the hierarchy of study design and what type of question it is that you're asking, and then go find the highest level of evidence that will help you answer that question. And remember, librarians and informationists are like worth their weight in gold. They can help you set up search strategies and alert you to new things coming in. Find a checklist you like and make sure that it includes looking at validity, the size of the effect, but at the end of the day, you have to use your common sense. There's a lot of self-interpretation that goes into looking at results, and just because they tell you it's important doesn't mean it is, or it might not be for you or your patient or your work. And yeah, don't forget the practical stuff like cost and feasibility, and do remember my point about not changing practice based on one paper, because hopefully all the things I've told you about today, like dogs on editorial boards, will make you realise that not everything you read is good quality. So that's it from me, and we've got a few minutes for questions or comments if anybody has some. And I know that's a ridiculous whirlwind tour, it's a massive topic. Usually this sort of thing's taught over a few days and you review papers and do workshops and things, but hopefully you've got an idea about what it is, why it's important, and why all of us working in clinical settings should know what critical appraisal is and have some basic skills. Any questions? We have a microphone if anyone's got a comment, a question, anything offline. I've completely bamboozled you. A lot of it is a bit boring, especially when you've got to pick apart confidence intervals and things, but there's a lot of eyeball things you can do in a paper. And even if the only thing you remember is don't believe everything you read, know what sort of study to go find if you've got a question. That's probably a good start. Well, if there are no questions, I'm very happy to stay behind for a while if you're feeling shy and chat to people then. But thank you all for coming, and if you get an email about evaluation, please fill it in and I will adjust my talk accordingly.